All right, thanks very much. That was a great discussion. So these are my disclosures. So I figured we'd start out with a couple things just to say when we're looking at spinal deformity, the first important thing to realize is that it's actually very common. So scoliosis has been observed on plain X-rays with a range of 8% to 68% of the time. So it's something that you're going to see, and something that you should certainly familiarize yourselves with, because it's definitely something you're going to treat very, very commonly. It's also important that X-rays are utilized in the majority, or if every patient, because through X-ray, you will catch scoliosis. It's pretty common to get an MRI and to only look at the MRI, and you could easily miss a scoliosis because usually X-rays are standing, whereas MRIs are laying down, and so a scoliosis is often more pronounced when the patient is standing. So a further reason why X-rays are a very important part of this patient population, in addition to the fact that X-rays are the foundation for our ability to assess the patient's disabilities and their pelvic incidences, and all of the radiographic drivers for disability are all determined from X-ray. So, and also it determines motion, and dynamic studies are very important in this patient population. So those are the first sort of tips. So we're all familiar with these radiographic drivers of disability and the X-rays needed to assess these, the degrees of the deformity and the degree of correction that's needed. And very important to pay close attention to all of these parameters. So the next most important tip, I would say, we alluded to this yesterday, is that patient selection. So it's very important when you're looking at spinal deformity patients to select your patients carefully and to not jump into surgery, and to discuss all of the potential pitfalls and hurdles that could occur, because this will save yourself many future long discussions in the event that complications occur after surgery. So in general, you need to evaluate these patients for several months before signing them up for surgery, and try to get them optimized in a multidisciplinary fashion. So we're gonna now, those were sort of the methodological tips or conceptual tips. Now we're gonna go through surgical tips and tricks, and we're going to use various different case examples, and we're going to go in a progression of complexity from open to less invasive. So we'll start out with this patient. This patient is a 51-year-old with a history of kyphoscoliosis, had 2 previous surgeries for treatment, one of which was anterior, the second of which was posterior, and you can see she is left in a profound positive sagittal balance. She has worsening pain, was recently involved in a motor vehicle accident, and that just threw her over the edge. So most important thing to know in this situation is the fact that she is fixed. She has a fixed sagittal plane deformity. So, so what are your thoughts on that anterior hardware? Is this patient with her fixed sagittal plane deformity, is this patient going to be capable of having her correction in the presence of that hardware? Yeah, so it's you're stuck, So basically, this surgery, in order to be performed, required removal of the anterior hardware, and so the main tip for this case is to familiarize yourself with the vascular surgery colleagues at your institution, so that when you have cases like this where you are forced to do something from the front, that you have access to someone who can help you and manage that situation. So for this patient, that was step one. So now we're sort of starting from scratch, so this patient no longer has that anterior instrumentation, still has a pretty profound positive sagittal balance, has a fixed sagittal plane deformity. So this is one of those patients who needs a large amount of correction. This patient ended up needing about 40 degrees of correction when you made all the calculations, and so this patient underwent the second stage of her operation. During the operation, there was a massive durotomy, and a Duragen patch was placed. The patient had severe blood loss.
Wait, how massive was it?
So there was a piece of calcium. So given that this patient has had previous surgeries and that she had this calcified fusion mass, she also had a calcified ligamentum flavum. So there basically was a very large defect in the dura after removing this calcified ligamentum flavum that was adherent to the dura. And so as you all have witnessed, if you get a bad durotomy, you get a lot of epidural bleeding. And this patient had a large exposure. There was a pretty profound blood loss. And so it was at that point, no PSO had been attempted. She was relatively stable. So we made the decision to actually close the patient and get her resuscitated. And so that's one of the tips, is that it's if the patient is becoming hemodynamically unstable, or if you feel that the patient's starting to bleed quite substantially, and you feel like your anesthesiology colleagues are not appropriately resuscitating the patient intraoperatively, the safest thing to do is to close and get the patient resuscitated. And so that's what we did. And this was her intermediate stage prior to the PSO, and so finally we ended up doing the PSO, and her outcome was good. She was happy. And that was that. So it was about a 3 or 4 day period after that second surgery that she had her third surgery, and knock on wood, she didn't get an infection. So that was basically as maximally invasive, as things generally get, other than the en bloc resections that Dr. Mendel showed us yesterday. So now we go to the opposite end of the spectrum. This is a 52-year-old, actually a dermatologist, comes in with pretty significant back pain. She can no longer do her Mohs surgeries because of the severity of the pain that she's experiencing. You look over there and you can see that she has a 16-degree mismatch. She's very interested in minimally invasive approaches. But her primary problem is back pain. And she comes in asking for MIS surgery. And my knee-jerk reaction very often when a patient comes in asking for something is to say, oh, well, I should be the one really deciding what to do. It shouldn't be the patient. But very often, especially if the patient is someone with who you can tell is intelligent and has thought a lot about this, and has usually seen multiple other physicians, I think it's reasonable to not just automatically dismiss their idea. You should listen to your patients and see exactly what it is that they're getting at, what's their reasoning, and don't just dismiss it if the plan is reasonable. David, what are you going to say?
No, I was going to say, before you bias anybody with what it is that you ultimately did here, can we poll the audience?
Sure. So this patient has this curve. She is relatively balanced. She has a 16-degree mismatch.
Tyler, what are you going to do?
Well, I got to figure out where I think her pain's coming from, because the curve is not impressive. I don't think she has a real mismatch, right? I'm not worried about her sagittal alignment. If we instrument it, we got to pay attention to it, but I think she's fine the way she is. If she had a real imbalance, her pelvic tilt would be higher, right? So she's probably leaning a little bit because she has some pain. So I'm just trying to figure out a pain generator, whether that's set injections or whatever. I got to know that right, if it's back pain, not radiculopathy, right? I mean, just because that one level looks really degenerative there doesn't mean it's the pain generator, right? That's how all the stories of 5 back surgeries start. No. But right, I'd
Yeah, so
work through and try and figure out where I think that is.
The areas of sclerosis, she points straight to that area as far as where her back hurts.
I would do exactly what Tyler just suggested, and I would start with a 5-4-3-2. I would start with L2-3 facet blocks to see if she gets temporary relief from facet blocks of that one level.
Yeah, so she went through the routine conservative measures, including core strengthening, injections.
Yeah, I don't mean conservative management. I mean I want this as a diagnostic modality. So I'm sending her for facet blocks not because I think that is a treatment for her spinal disease. I want an L2-3 facet block to help me understand from a diagnostic perspective of whether that is the pain generator.
Yeah, that's reasonable. Go ahead.
I just have a question. When you're studying whether the facets are the pain generators, do you look for imaging correlates? Because the facets is looking at
The facets. So the facets were hypertrophic to some degree, but not severely. I think most of her pain was related to the facets. She did get facet injections, and they did relieve her symptoms temporarily.
Do you think they work, really? I mean, in our experience, we have great conventional pain guys. In the presence of hypertrophic facets, it's such a crapshoot. And when they come back negative, then what do? Are you turned off that level being the pain generator?
Well, I resort to either an epidural steroid injection after that to help determine whether or not there's a nerve component.
Let's say that I had a week's relief and then it did nothing.
Well, it's
I'm just saying this is
Yeah, so a positive response to a facet block is far more valuable to me than a negative response. So a negative response, I don't know how to interpret that, but a positive response is very valuable information to me.
so this patient was continuing to have worsening symptoms, and ultimately ended up getting a minimally invasive lateral approach with percutaneous screws. And she had a speedy recovery and did very well. So this is a 74-year-old with a previous lumbar decompression in the setting of scoliosis, who was having substantially worsening back pain and leg weakness. He had residual foraminal stenosis, but the center of his spine was decompressed. And whoops. So in this patient, my thought process he was 74 years old. He had multiple comorbidities. It's hard to see over here, but from L4 to S1, he's actually fused. And his symptoms were really primarily coming from the areas of olesthesis. And so I didn't want a surgery that would result in massive blood loss, nor was my goal to get a complete correction in this 74-year-old. So we resorted to a OLIF approach in this gentleman. The most caudal segment, there was a tremendous amount of EMG activity with any manipulation of the psoas in that region. That was the L3-4 interspace. And so, so it ended up being such that we had to do a posterior TLIF at that segment after we were done with the front. At the L2-3 segment, the ALL was released in order to improve the overall sagittal alignment without doing a large construct. And the patient had a substantial improvement in the sagittal alignment. It wasn't perfect. Coronally, he looked quite good.
Yeah.
And he was very content.
So this is a limited fusion, and I think there's a role for this in many circumstances. I actually took care of a lady once who I thought needed a real correction, and she wanted to go see Keith Bridwell in St. Louis, and she went, and he did basically this operation, and she got 7 years out of it. I saw her back recently, and it's finally starting to cause her problems, and so she got 7 years out of a limited fusion. That's a great thing. But if you go back to that lateral standing X-ray, this makes me nervous. The abnormal angulation above the construct, I haven't measured everything out, but I wonder if there is harmonious lumbar lordosis here. And so I look at that X-ray, and I can't ordain the future, but that X-ray makes me nervous that this person is on a shorter course towards reoperation.
Yeah, I share that concern. And as you notice, the rods were left long on purpose. So this is a 55-year-old with no previous surgery, several years of conservative treatment, and was just having very substantially progressive worsening of her back pain. And these are her parameters. And so you can see that there's a reasonable amount of mismatch. She has a relatively large curve. And this patient is someone in whom I contemplated lateral surgery. But one of the things that I noticed was that she did have a reasonable amount of gas in multiple disc spaces. And this was a situation where I thought that we could potentially treat her posteriorly with some expandable cages to help restore some of the anterior column height. And so the strategy was to address some of the coronal aspect of the curve by putting the cages in on the sides where the arrows are.
Hold on, Charlie. Are these vacuum discs making you more or less likely to go lateral?
So these vacuum discs, I thought were equivocal. You could go laterally or posteriorly.
These vacuum discs are what make Adam Cantor salivate. You know,
yes.
This makes him so enthusiastic. And then the blood loss of an L-lif is a fraction of the blood loss of a T-lif.
In your hands at the time.
In our hands.
Yeah, so you know, my issue with that approach is that the way I think about it is that very often these patients, it's hard to convince them to have two surgeries. And you know, they very often they come to me having mentioned that they saw someone and they were going to do two different surgeries, and they just are not interested in having a complicated hospitalization. So this is someone who.
MRI of 5'1".
So Tyler and Juan are back here saying Tyler has told Juan he'll race him, and Tyler thinks that he can do this faster posteriorly than Juan can do it side back.
Yeah, because basically we try to kill someone and he just gone with a bazooka and throw it there and just trying to find it and just do exactly what it needs. But, what I'm saying is like 3 mini open T-leaves is way much different than 3 laterals and PERC screws. So he was going open laminectomy and T-leaves. Obviously, he will win the race big time.
Well, I mean, it all depends on what levels you're
Can I
doing.
see 5'1" on the MRI? Because to me, it's a big deal in here. If 5'1" is good in this case, it will be, I mean, on the MRI, the disc looks decent and there is no problem. To me, it's a, you know,
So this is the
5
original.
case.
I mean, that deformity extends up to the lower thoracic spine, and there's a thoracolumbar-junctional kyphosis. You're not
I
doing.
didn't see that part. Oh, wow.
Oops.
Oh, but that's different now.
No,
It's a
that's
different case.
that's the one. That's the one.
Okay. Yeah, that's a different.
But when you have vacuum discs like that means like those things move. You don't need interbodies at all for those, right? The only interbody I'd place is at 5'1". If
Well, in this case, I wanted to put interbodies in order to help improve her anterior height. So this was the final result. You may remember how you see how collapsed it was.
Yeah, her deformity is completely different, supine and
You
standing.
see on the CT, that thoracolumbar kyphosis almost get corrected. You on the lateral CT? That's, you have this, someone there? You have a CT there. Yeah, see that one, that thoracolumbar junction is not as, it's a big, it's like two different patients, you know, like on the compared to scoliosis standing. You see 5, 4, 3, 2, you know, 12, 11. It's amazing how much he relaxed on the CT.
Yeah. So I mean, I do think that in the end, this is what we did.
Yeah.
You know, so she ended up doing well, but the argument is that could we have done something smaller, and it's possible.
And did you put a T at 5'1" or you did?
In her case, she did not have much stenosis at 5'1", and so we did not T-lift it, and we extended the fusion down to the pelvis because of the long nature of the construct.
what did you do for fusion at the bottom at 5'1"? Did you use biologics or
BMP.
like a full
And-
kit?
What's that?
Full kit at 5'1"?
Oh, not just 2 large packs of BMP for the entire construct.
Charlie, why did you put too many rods down? You did osteotomies there or something?
Posterior column osteotomies. And so, in the process of putting in these interbodies, and this is very similar to Jens' discussion yesterday. What I've realized is that you could really stretch the ALL pretty considerably and have a substantial amount of correction, an enhanced amount of correction from a posterior column osteotomy when you stretch the ALL. And there are many different ways to do it. I find that the disc spaces that have the gas in them, similar to the lateral surgeons, when you have a disc space with gas, you can very often expand that ALL and put in a nice anterior cage and obtain a substantial amount of correction from a posterior column osteotomy. So depicted over here is bilateral dilators that are placed in a very ventral fashion, almost to the point where you're pushing the ALL forward or even almost penetrating the ALL to further mobilize and enhance the amount of dynamic stretching that you can get from that process. So, this happens to be a patient who ended up getting a 15-degree or 14-degree correction just from a posterior column osteotomy by stretching that ALL using that technique. This is another example of stretching the ALL. As you can see over here, there was a large osteophyte and a significantly collapsed disc space. And over here, you can see how much the disc space expanded. There is some subsidence, but there's definitely an improved angulation from just 2 posterior column osteotomy procedures with the lengthening of those anterior regions.
Hey, Charlie, can I make a quick comment? So, in your hands, you described this to me at dinner last night. So, in your hands, you can execute this beautifully with relatively low complication rate, right? Does it concern you to really teach this technique to everyone that, this is a nice technique, less blood loss, all these things? And remember, we're pushing against the ALL the whole time to really to get the correction that you want. Are you worried that we may be setting people up for catastrophic complications here versus, let's say, doing a PSO, which has its own set of complications, but here, if you get in trouble, you're really in trouble?
Right, that's a good point, Isaac. I think that, when you're stretching the ALL and just trying to get a cage very ventrally and completely removing the annulus, it's a different entity than breaking through the ALL. And this is this next case was actually breaking through the ALL, and that actually is very risky. And I've come to see that it's possible, maybe not necessarily recommended 100% of the time, but this is a technique that I consider for patients in whom I was going to consider doing a PSO. And, whenever you do a PSO, you have to do a 3-column osteotomy and remove a large amount of bone posteriorly. And then as you go anteriorly, you try to create that wedge.
Can you show the film with the cage in place? So in my experience in this situation with that pre and post-op image, there's enough redundancy and residual buckling of the ALL that for what Charlie did there, that can be achieved without section of the ALL.
Correct. So in these cases, the ALL was not sectioned, and for that reason, the cage was capable of being placed without the concern of it, migrating into the abdomen.
These are expandable cages too, Charlie. So.
Yes.
Right. So the whole risk involved is less when you are expanding and have the tactile feel with flow of where you're localizing.
So I think where Isaac's concern comes up in this situation right here. So this is basically a patient with an ossified ALL. So like I said, in patients with ossified ALLs, where you are contemplating doing a PSO, sometimes during the PSO process, you may notice that the spine can become very brittle and will actually crack on you. And this is a situation where this unfortunate patient needed, substantial amount of correction. And as you can see, the old definition of a Smith-Peterson osteotomy is a posterior column shortening procedure and an anterior column lengthening procedure. And so you can basically plan for the PSO, and as you're drilling, don't drill the full amount posteriorly, drill it partially, and then go into the front and test the waters to see if the spine will crack. Obviously, a temporary rod will be in place, and we use blunt shavers and dilators to penetrate or get close to the ALL.
When did you do this case?
So this was in, I think, around 2011.
Yeah. Would you make the same decision today for this patient?
I think this patient, we didn't really go through the history of this, but this patient had this this lateral plate right here and had previous scarred dura in this area. So this was virginal territory right up here. So I wanted to do the 3-column osteotomy up there.
So this goes to, and I don't have the measurements there, but if you go back one slide, if you go back to that slide, so this is a person with a low pelvic incidence right there. Okay, so that's low to mid, but that really looks like low pelvic incidence to me. Okay. And then when I look at that AP X-ray and that CT scan right there, this is now the patient where I would do what Jens showed yesterday in the live demonstration. And the harmonious, so remember, the low pelvic incidence patient, the harmonious lumbar lordosis produces the apex of the lumbar curve in the lower lumbar regions. Okay, so the higher the pelvic incidence, the higher the apex. So what you did, to me, in my 2019 thinking,
right,
you did the correct operation for the patient with high pelvic incidence. But for a person with low to mid pelvic incidence, what I would do, and it spares the person the 3-column osteotomy, is I would do what you guys saw Dr. Chapman do yesterday, and at 5-1, I would do an osteotomy, and I would get this thing jacked up at 5-1, and then I could get some extra stuff at 4-5, because there's just enough at 4-5 to let you do what you saw Dr. Chapman do yesterday, and I would create the harmonious curve from L4 to S1.
What about the Koski maneuver, doing actually the PSO on the sacrum? What's the name of that? Sacrum?
Yeah.
Well, I call it a sacral subtraction osteotomy. No,
Yeah, this-
I don't think you. Yeah,
Yeah, this patient also,
that's a fracture, right?
yeah, this patient also had a pretty bad sacral fracture. Yes.
Yeah, that's a fracture.
And yeah, yeah, so you can see that it healed nicely. That was a fracture. She fell. So anyhow, that was her final result, and all right, so our time's up. So I guess our next thing is a break with exhibits, and then we'll have Juan come up at 10:15 for current concepts in lateral surgery.